Hi, everybody. I'm very glad to be here. Thank you for having me. I am told that I must say this, and it is true, that I have no financial or other conflicts of interest relating to the material in this presentation. I speak the truth. So when I first was looking over the materials for this conference and I read the title of this talk, Balancing Act, I thought, oh wow, that sounds really interesting. Maybe I'll be able to get some tips or advice. And I said, oh, that's me getting that one. So hopefully I'll be able to impart some of my story, if not answers, to how to do this. I'm sort of the color commentary to the scientific piece of the morning, so you're going to hear a little more storytelling and a little less scientific presentations. I want to focus, at least in the first few minutes of my talk, on what I've come to call my vocation, and is something very, very important to me. And I'm really kind of a Jesuit deep down inside my heart. So Jean-Pierre de Caussade is very much all about the will of God and finding the will of God in your everyday life. And so I put this quote in because it's very meaningful to me, as much of his writing, that the will of God is constantly before you like an immense, inexhaustible ocean that no human heart can fathom. And for me, that's very, very true. And I try to approach my everyday life looking for what's the will of God in my life today, and then hopefully trying to carry that out in the best way that I can. So this is sort of the path that my life and career have taken so far, and I'm going to just walk through briefly some of these pieces, and then we'll get to some more ethical issues in a few minutes. My story is similar to that of many, many others. It's one example of how God calls each of us as a unique person in this world, in this hectic and chaotic world sometimes. It's really not a story about me. It's just one example of what God can do and the work that He does do every day in our lives. So I don't want to shine the light on me, but rather to shine the light on God for the work that He does in our lives. So I was really, have known I wanted to be a doctor since I was about 12 years old. And I can remember the day and time that came to me because I was a Girl Scout. And I was touring the county hospital at the time as part of a Girl Scout trip. I was 12. And we toured the pathology lab, of all places to take a troop of Girl Scouts. But for whatever reason, that's where we were. And I saw all the jars of eyeballs and brains and organs up on the wall, and actually ended up hanging out about 15 minutes with the pathology tech and lost my Girl Scout troop because I was so interested in all these jars on the wall. And fascinating, he showed me the eyeballs and the optic nerves in detail. I just thought that was so cool. So from that day forward, I said, you know what, I really want to be a doctor. I think that's what I want to do. A piece of that grew as I grew older. I was only 12 when I was looking at the eyeballs, but a part that kind of supplemented that over the following years was the realization that I really had been given so many gifts from God. I was raised in a pretty easy, typical suburban lifestyle, Catholic school. I was given pretty much intelligence. I got through school pretty quickly, and so I realized I was given all these gifts, and that it was my duty, obligation, call to give back to society. And so that really combined with my love of science and the human body to really gel the fact that I wanted to be a doctor. I went to college. My alma mater, anybody know? At Notre Dame. Touchdown Jesus on the Golden Dome. And college at Notre Dame really continued to shape who I was. And part of the message I want to impart is this was the hand of God moving me through all of these places and experiences. And I didn't even necessarily realize it at the time that I was going through it. But only in retrospect, when I looked back and said, oh, that's why this or that happened to me, or that's why God put me in that place at that time. But Notre Dame was very much like that. I got involved with the Center for Social Concerns at Notre Dame. Notre Dame has a very large service culture, for those of you that know Notre Dame. And a couple summers I spent in the inner city of Milwaukee doing social service projects through Notre Dame's programming, homeless shelters, women's shelters, things like that. And that continued to hone what I call a call to service. Being able to feel comfortable in those kinds of situations, and being aware that there are other people that need your help and that you can help. Those were all really important to me and honed through Notre Dame. I spent my medical school time right here in Chicago, just up the street a little bit at Northwestern. And during the 2 summers of my life here in Chicago, I spent at community health centers in Chicago. One called Winfield Moody Health Center, which is located right adjacent to Cabrini Green, which this is a picture of the old housing projects. And when I was at this health center, Cabrini Green was still there. And quite an experience for me, living in Milwaukee and South Bend, Indiana, to be in the middle of housing projects. And honestly, I was pretty scared. And I drove into the parking lot with huge wire fences with barbed wire over the top and wondered if my car was going to be there when I got back out. But again, I think all of these experiences helped me to see that, yes, I could do this, and that there was a need out there that I could fulfill. Little old me could do this and could help these people in this kind of scary, what I thought to be a very scary place. This is a fuzzy picture because it's so old and I couldn't find a newer one that was more like JPEG friendly, but but this is Claretian Medical Center, which is down on the far south side of Chicago, and I spent another summer there. And ran into a woman who was the medical director of that community health center at the time. And she was this little spitfire of a redheaded woman who drove this old Ford pickup. And I just thought she was the neatest person that she could run a health center. And she had a master's in public health degree, and I said, you know what, I want to be just like her. She's really cool. So I decided I better get my master's in public health if I wanted to do this and be like her and run a health center. And I did that at Northwestern while I was in medical school. But again, all these pieces just kind of fell into place because the hand of God was there, just guiding me where He wanted me to be. Call to the poor. You can see the pieces already lining up. But when I was in residency, a typical internal medicine residency is very much hospital-based, it's very institutional, and I was able to sort of talk the leaders into doing my continuity clinic, it's called, in the inner city of Milwaukee, rather than sort of at the hospital campus where the traditional programs are done. So this is where I was able to do my continuity clinic, kind of right in the heart of one of the most areas with the highest poverty in Milwaukee. But again, it was like an exception to the rule. I was allowed to do it at my request, but it wasn't typical. And again, I'm just trying to point out that the hand of God was in all of this. I finished my residency program, and all of these experiences led me to know that I was meant to serve in an underserved area of Milwaukee, really. And so when I finished my residency, I looked at all of the potential places to become employed as a physician in Milwaukee's inner city, and there were about 3. And fell in love with my current employer, which is 16th Street Community Health Center. So this is 16th Street. We're located on the south side of Milwaukee in a predominantly Hispanic patient population. And part of what I fell in love with was the mission statement, which if you walk into our clinic, most of our employees, and we have about 300 employees now, most of our employees can at least give you the gist of our mission statement, maybe not word for word, but pretty close. And it's about providing quality health care to all comers, to all patients that come, regardless of linguistic, cultural, and economic barriers. I'll talk a little bit more about what that means, but for me, that was a real draw to the clinic. Also, the cultural piece We serve an area of Milwaukee which tends to be the place where new immigrants arrive to that neighborhood. It's a very, very poor neighborhood. But some of the newer immigrant groups tend to come to our neighborhood. So we've had more recently some Middle Eastern immigrants. We had the Hmong a while back. And I really enjoyed that multicultural aspect to providing medicine, not always in your own language, not always to people who share the same culture as you, but it was really interesting to me, to that facet of it. So I fell in love with 16th Street. And pretty quickly after I arrived there, I was kind of moved right into a director position within our internal medicine department, which was kind of a shock to me because I wasn't really looking for it, wasn't really maybe formally ready for it, although I did have it was on my radar of something I had wanted to do in the future, but really kind of not at that time. But again, I think the hand of God was in all of this. I say I wasn't quite ready for it because I hadn't yet had started my family, and I knew I wanted to have kids, and so I was kind of wondering, well, how the heck am I going to juggle all of this? But I did become a mother, and this is my son with diabetes. That's him when he's 2, and he was diagnosed. It was actually a very devastating time in our lives, even as cute as he is. But he was 2, and diagnosed with diabetes, and that's his little diabetes kit that he had to carry around everywhere. So he went to nursery school with his little. That was his first day of school with his huge old diabetes kit, almost bigger than he is. That's him today, a couple months ago. Typical 16-year-old kid. I wish he'd cut his hair, but I don't have much control over that. Justin Bieber, yeah. I don't get it, but. So I want to tell you a little bit about 16th Street. This is, when I started there, this was the only site that we had, but since I've been there almost 18, 19 years now, something like that, we've added additional sites. This was a site we added in 2006, and then just in 2012, we added a site in the suburb of Milwaukee called Waukesha. We currently serve about 33,000 patients in our service areas, mostly on the south side of Milwaukee, but also now in Waukesha. We do about 120,000 patient visits a year. We have about 50 docs and mid-level providers, nurse practitioners, physician assistants, and about 25 mental health counselors. The vast majority of our clinical staff are bilingual in Spanish and English because of where we're located. We serve a patient population that's about 80% Hispanic. You can see the rest of the statistics there. The sort of other category of Hmong, Arabic, Burmese, etc. shifts over time. So depending on who's in the neighborhood at the time, that tends to shift, which I actually really enjoy. The insurance status of our patients is highly Medicaid and uninsured, and part of the reason our mission statement is so important to us is that we're able to provide care to anybody who comes, regardless of whether they have insurance or if they don't have insurance. And we see healthcare as a right for everybody, and we're so grateful and happy to be able to provide that healthcare to people that otherwise wouldn't be able to get the care can come and get care from us. And one of the statistics I'm most proud of is the fact that for our diabetic patients, there's an outcome that we track called hemoglobin A1C for any diabetics in the room, but it's a test that shows how well your diabetes is controlled. And for our uninsured patients and our insured patients, whether you have insurance or not, the outcome is exactly the same in terms of the quality of your diabetic care. And to me, that just says the world about what's important to us. It doesn't matter if you have insurance or not. It matters how well your diabetes is controlled, and we'll do everything we can to get it well controlled. So, enough bragging. We deliver about 700 babies a year, and so these are some pictures of some of our families. We also have a geriatric population. This is one of our doctors with one of her patients. I wanted to just say a little bit about what is a community health center. It's also called a federally qualified health center. I much prefer the term community health center because I think it's so much more indicative of what it is we do and what our mission is. Meaning that we are in and of the community. We're located in the heart of the community. Most of our staff come right from the community. Many of our staff this is their first job, and we're able to give them a leg up and learn how to have a job, learn what's the appropriate dress, what's the appropriate language that you utilize when you're at work. So we are in and of the community, and 50% of our board of directors needs to be from our community. So the whole purpose of all of that is that we're actually doing things that the community feels that it needs. Programs, prevention activities, etc. is all directed by the community that surrounds the buildings. So we're an independent 501c3 organization, which just means we have our own independent board of directors. We're not owned or operated by anybody else. We're our own organization. We're very focused on the mission, as I said. We're required to be in a officially designated medically underserved area, which means there aren't enough doctors that see those patients in the area, so that's why we're there. And like I said, we have to have a board of directors representative of the community. The federally qualified piece comes in when we talk about our federal grant, which is about 10% of our total budget. But it is accompanied by a lot of federal regulations and lots of report submission and all sorts of extra things that we have to do. The federal grant does allow us to provide our sliding fee scale to patients, so our uninsured patients need to fill out an application stating what their income is, and then they're able to get on our sliding fee scale, which for most people is a $10 copay per visit, which covers everything. 20 vaccines if you get that many, pap smears, whatever services are provided at that visit. One of the things that we really do is try and be focused on community health. So not just that one-to-one visit with your doctor, which is of course very important, but also what are the activities we're able to do in the community to affect the health of the community. And I put in some pictures of some of the things that we do to that end. This is our Parenting Resource Center. So parents that are having problems learning how to be parents can come here and get advice while interacting with the children. There's a teacher that's available to teach the parents how to best interact with your kids in a way that's going to foster the best learning and best growth and development for your child. We run exercise, Zumba, and Nia classes for the community. We have a community garden, and along with that we teach people, some of the farmers that came from Mexico actually teach us, but we all teach each other, I guess, how to cultivate the best vegetables. We do some river cleanup in the local river that tends to be pretty polluted, so 2 days out of the year, staff and patients go out and clean up the river. This is one of the health education classes for the kids. And then we also sponsor a walk each year at the Mexican Fiesta, which is a big festival in Milwaukee. And Elecciones Saludables means healthy choices. So this is a group from 16th Street that walks every year, about 200 people. So that's kind of what I do and where I came from and how I got here. We wanted to talk a little bit, since this is a bioethics symposium, about what are some of the bioethical issues that arise. And in a minute I'll turn it over to Erica, who's going to be doing some formal comments from an ethical perspective. But for me personally, I think I told you about my faith life and how I feel that this really has been a vocation given to me by God. I think the question is, why am I in a non-faith-based organization rather than a faith-based organization? And what does God want me to be doing here? I think as the Bible says, God's ways are not my ways, and if I had my way, I would be a missionary somewhere in another country. That's really what I want to do. But every time I ask God if it's time to do it yet, He says, no, stay where you are. So I'm still here. But but my point is that I think that sometimes being a faithful person in the public arena has its challenges and can be difficult, and that's some of the issues that we want to talk about. But one of the role models that I've come to learn more about in the past few years is a woman named Madeleine Dobrel. She's French, and she's a social worker who lived in Paris and did most of her work in the 1940s, 50s, and 60s. And there's a collection of her works out now called We, the Ordinary People of the Streets. And she talks about how her mission fields are really the subway systems, the neighborhoods where people work and play and live. And she lived amongst the communist communities and purposefully located herself in the middle of communist communities so that she could evangelize those communities. And so I find a lot of strength from her because I feel sometimes like her, I'm in the middle of a bunch of people that maybe don't believe the same things that I do or aren't of the same faith that I am. And so I find her very, very interesting and apropos to what I do. That said, Erica Latham is our bioethicist, she's going to talk about some of these ethical issues that arise. Thank you for your time and attention.
Thank you, Dr. Schuller. It's a privilege for me now to introduce Erica Lake, to respond to Dr. Schuller.
Hello. As Dr. Schuller mentioned, I am an ethicist. I thought I'd just take a second to explain what that means. A couple of years ago, I was called in by one of the physicians with whom I work at Presence Health to help him work with a family who was dealing with difficult end-of-life decisions. So he calls his family, they're divided, they need some help, they need some guidance. Can you meet with them tomorrow morning? I said, sure, 9 a.m. So that morning I walked into a patient and family meeting room to a room full of very nervous individuals. And I explained, my name is Erica Latham, and I work as an ethicist, so I help healthcare providers and patients and families who are making difficult medical decisions. And I saw this collective sigh of relief in the room. And then they started to laugh. And not knowing what was going on, I just remained quiet. And one of them looked at me and she said, "We can't tell you how relieved we are. We thought that the doctor had asked us to meet with the exorcist." I have no competencies in that area, but I can share with you a bit about our Catholic tradition and how some of the questions and topics that Dr. Schuller raised can be seen in light of the tradition as a whole. So a little roadmap today. I know she gave us so much to unpack. I'd like to focus just on two areas. So one is to share some thoughts on professional vocations that some women have in the field of healthcare. And then I'd also like to talk a little bit about the principles of cooperation, which is part and parcel of Catholic moral tradition and is particularly relevant in those circumstances where we as Catholics are somehow present to what we understand to be the wrongdoing of others. So some thoughts on the professional vocations of women in healthcare. Like Dr. Schuller, I too sensed a vocation to go into the field of bioethics. For me, the vocation or the calling came at a very precise day, at a very precise time, and in a very clear way. Not everybody has a calling in such a clear way. For others, it's something that one discerns over a long period of time. Well, what is this concept of vocation? The word vocation comes from the Latin word vocare, which means to call. Oftentimes we hear the term vocation discussed in reference to one's state in life. For example, a calling to the priesthood or religious life, or a calling, a vocation to marriage. But vocations can also be found in the professional realm. A vocation properly defined is a calling from God to a particular service. And a service is oriented towards helping another or others achieve some definite goal. I think it's important to point out that a vocation, including a professional vocation, is not something that's ultimately oriented towards the self, towards self-fulfillment per se, but rather it's oriented towards the fulfillment of others. It's a service. Now, when it comes to the service of a vocation in the healthcare field, I think that there's so much that we could talk about in the tradition, in our history as Catholics, about how women have played an important role in that. I could talk about the women religious who played significant roles in founding the Catholic healthcare community in the United States that we have today. I could talk about people like Mother Teresa or Mother Mary Ann Cope, who responded to particular needs in their community by forming homes for the dying or homes for the lepers and to deliver care that way. But since there's so much to unpack, I had to focus on just a few. So I'm going to focus instead on some individuals who are now either saints or blesseds, who had something to say in particular about the vocation of some women to a profession in healthcare. So the first is somebody by the name of Edith Stein, also known as Saint Teresa Benedicta of the Cross. Edith Stein was a philosopher who studied under Husserl. Husserl was a phenomenologist, a great German scholar. She was a convert to Catholicism. She was born Jewish, and through her encounters in the university with Catholics and Catholic thought, became very intrigued by the Catholic intellectual tradition, and ultimately became Catholic and then a Carmelite nun. She was ultimately martyred in Auschwitz. Edith Stein has a very interesting essay on the feminine vocation. She writes about women pretty extensively, in particular on the feminine vocation. And in this essay, she says that the care of humanity and of human life and in general has been entrusted in a particular way to women. And we see this in the vocation of motherhood, the particular contribution of women to the family and in a home. But she also sees it as a contribution that some women are called to make beyond the family and the home in the professional field. Now, keep in mind, she's writing at a time where women, as physicians in particular, was not exactly a common thing. There were some pretty significant barriers, which she addresses in the essay. At the time, one of the great concerns was, would it be immodest for women to learn such things about medicine and science? Does it shatter their innocence to do such a thing? And then also raising questions about whether women would be capable to meet the rigors, even the physical rigors that the field of medicine involves. Recognizing that some women are called to work in this field of healthcare, she called for those barriers to be removed so that women could accompany others, and in particular their sisters, as they encounter medical dilemmas. Another person I'd like to focus on is one by the name of Saint Gianna Beretta Molla. You know what? I think that we're actually missing a little bit of content here. I wonder if, I'm just going to check and see if perhaps an older presentation was uploaded here. It's there. The error is human to really screw up. It takes some technology, right? Okay. So I don't know, but for some reason some of those letters aren't appearing there. So Saint Gianna Beretta Molla was a Catholic wife. She was a mother. She was a physician and ultimately a saint. She was a mother of four. Colleen Carroll Campbell was one of her biographers. Really does, I think, a great job summing up her life. She does mention that she had a really great housekeeper who allowed St. Gianna to keep that balance between her professional work and her family work. Now, St. Gianna actually wanted to be a missionary, someone like Dr. Schuller. But when she spoke with her spiritual director about it and discerned that vocation, they recognized that she didn't have the physical strength, she had some health issues, that would allow her to go to the ends of the earth and in some really difficult physical positions. Her spiritual director told her, you know, if God is calling you to something, he'll give you the physical means to do it as well, and it doesn't look like he's giving you those physical means. So instead, St. Gianna went on, she went to medical school, she became a pediatrician, and it was in her work as a pediatrician that she found her mission. And she says at one point in her writings that the physician can go places where priests cannot go. And the task of medicine is not only to cure, but also to care. And when medicine has run out of its possibilities, then the physician still has an important role. The physician's role is to bring the soul to God. It's not only the priest's role, but this is the physician's role as well. How needed, she says, are Catholic physicians in this area. Another person who's written extensively on the topic of the vocation of women is Blessed Pope John Paul II. He was a pope, he was also a philosopher. Some of you may know that he was a philosophy professor even before he became a cardinal. In 1988, he wrote a beautiful apostolic exhortation called On the Dignity and Vocation of Women, or Mulieris Dignitatem. Drawing from Stein, to whom he credits in other sources, he says that God has entrusted the human being to woman in a particular way, and he asks women to be a prophetic voice to call the world back to the primacy of love. In John Paul's thought, he sees in women a particular aptitude that he calls the feminine genius to call the world back to a place where human beings are the priority rather than efficiency, productivity, materialism, or other things. And he really exhorts women to use those gifts to transform all aspects of culture, the family, the church, but also healthcare, education, and any other field that we find ourselves in. In 1995, he wrote a letter to women discussing similar themes, and he had a number of audiences where he dedicated his Wednesday catecheses in St. Peter's Square to the topic of women. Several of them address matters of women in society, including discussions about equal pay for equal work, rewriting history in a less one-sided way, the contributions of women in education, healthcare, and care for the most vulnerable, etc. In the United States, the feminist movement has taken place in three major waves, and I think that we can talk about perhaps a Catholic approach to feminism, if one wishes to call it that, in that context. So the first wave here in the U.S. occurred in the mid-1800s. It focused mainly on suffrage rights, property rights for women, and women's admittance to higher education. The second wave occurred in the 1920s and 1930s and focused on education and employment opportunities for women. The third wave of the feminist movement is perhaps the one that many of us are most familiar with. It occurred in the 1960s and 1970s. It had much of the same emphases as before, but perhaps a new focus on what we might call sexual liberation. I should note that this wave of feminism did have different orientations. One was more moderate, one was more radical. The radical orientation of the third wave of feminism, where we see phrases like women need men like a boat needs a man like a fish needs a bicycle, or the suggestion that we rewrite the word woman, W-O-M-Y-N, so as to remove any reference to man, etc., has much more focus on the individual. And it's almost as though some authors see the feminine body as the source of inequality between men and women. And with that thought, the proposal is to liberate a woman from the inconveniences of the feminine body so that she can achieve full fulfillment as a woman. So in a sense, it involves denying those aspects of the feminine body that are unique to women, in particular, our ability to get pregnant. And that's where contraception, oral contraception, and abortion became very convenient mechanisms for the of that philosophy. Interestingly, when John Paul II is discussing women's full development and what he calls the new feminism, he doesn't suggest that we throw out the effort of women's liberation as a whole, which might come as a surprise to some people. He says that it's actually achieved some good goals. It's had some shortcomings that perhaps need to be rectified in a Catholic approach. And he proposes what he calls the new feminism. Now, there are several authors that have written about this topic. John Paul is certainly one of them. Sister Prudence Allen, who has written the great anthologies on the concept of woman, is another. Michelle Schumacher, who wrote Towards a New Feminism, is another. There's a lot to uncover there. But some commonalities I think that we see in this new feminist movement are a rejection of biological determinism, or this idea that biology is destiny, and at the same time a rejection of a pure social construction of nature. In other words, it sees both nature and nurture. It recognizes that we have perhaps some unique orientations, and yet at the same time recognizes that we're free and we have a reason and will. It sees the person as relational and men and women as equal in dignity and complementary. It promotes what John Paul called the feminine genius, or that essential nature or spirit of woman, and perhaps in particular a woman's unique ability to make room for another person. John Paul II saw this as something that profoundly marks the feminine personality. And in a lot of ways, I think he's drawing from Edith Stein in that affirmation, in such a way that even if a woman is never married or never bears a child in her womb, that he sees this as profoundly marking the feminine personality in a positive way, and in a way that allows women in general to accept the person in their concrete form. It's an approach that sees the fulfillment of the person in love rather than just individualistic self-pursuits. Sees all people as called to parenthood of some sort, so men to fatherhood and women to motherhood, be that spiritual or spiritual physical. Some of us are called to be biological mothers, some of us are called to more of a spiritual motherhood. The idea here is that everybody is called to go beyond themselves, to make of themselves a gift to others, and in that way to give life to others. Now, some practical implications, so reading a little bit from some of the authors that I mentioned before. What organizationally, some things that can be done to foster that balance, that Dr. Schuller was talking about. In the United States, I think we've made some great headway, but there's more that can be done. Paid maternity leave is an example. This is not something that's guaranteed for all women, which is sort of a remarkable contrast to other developed countries. Having access to health care. I think recently we've seen some statistics that have come out that show that abortion is actually down in all areas of the population except for the poorest. It's up about 18%, and one can't help but wonder if there might be a correlation there. Supportive breastfeeding policies, allowing working women the time to pump as was required by law, but also providing women with a space to be able to do that in a way that's not uncomfortable and is dignified for her. Affordable childcare. There are a lot of things I think that can fit into this. All right, now I'd like to move on to the second topic, and that is the principles of cooperation with wrongdoing. So the shorthand for this topic is just the principles of cooperation. I think for most of us, when we hear the word cooperation, we think of something that's very positive. Even from the time we were 5 years old and went to kindergarten, we learned you need to cooperate with others. Well, in the Catholic moral tradition, the principles of cooperation actually relate to something that's not such a good thing. It's related to principles of cooperation with wrongdoing of another agent. So just keep that in mind, that this might not be the kind of cooperation that we might intuitively think of. What is cooperation? Cooperation, in the ethically significant sense, is defined as the participation of one moral agent, so one acting person, the cooperator, in the activity of another moral agent, which we would call the principal agent, to produce a particular effect or joint activity. Cooperation becomes ethically problematic when the action of the primary agent is judged to be immoral. So questions related to cooperation arise in all aspects of medicine and for a variety of healthcare professionals. It can come as questions like, As a Catholic, can I work with integrity in an organization that shares some of my values, perhaps care for the poor, but it doesn't share all of my values, perhaps maybe on some of the life issues, we're not completely aligned. Can I be part of a medical practice where some of my partners are doing things that I understand to be morally illicit? Also, how do I handle requests from patients or from my employer to do things, or perhaps just to be present to activities that I find to be immoral and something that I would find to be personally problematic? So when we're thinking about principles of cooperation, think of the guy who's driving the getaway car after a bank robbery. That's cooperation. So he's not actually doing the bad deed, he's not actually robbing the bank, but he's driving the getaway car afterwards. Can you drive the getaway car? So that's what we're talking about for cooperation. We're not talking about helping somebody else to plant a tree. All right, so some context for the principles of cooperation. In history, the principles of cooperation in Catholic moral tradition came about primarily through the writings of St. Alphonsus. So if you live here in Chicago, you might know this beautiful church in Lakeview called St. Alphonsus, named after St. Alphonsus Liguori, who was a moral theologian. St. Alphonsus addressed this topic related to an individual. Much of the early literature is focused on helping a confessor in sacramental confession determine the extent to which the penitent is culpable for something that they were involved in. In time, we've moved from simply an individual understanding of cooperation to using the principles of cooperation for organizations as well. So, perhaps I mentioned before that I work for Presence Health, which is now the largest Catholic healthcare provider here in the state of Illinois. And as a Catholic healthcare provider, these questions come up all the time, and increasingly so, particularly now as healthcare providers are looking to become accountable care organizations, or as a result of the Affordable Care Act, are involved in the formation of accountable care entities where one organization is partnering with another organization in such a way to put together a package that individuals looking for medical care can choose from. The questions become increasingly complex and more relevant than ever. So this understanding of the principles of cooperation has been part of Catholic healthcare ethics for 400 years. In short, it guides whether and how someone may be present to the wrongdoing of another. And there are different ways of being present. It can involve ownership, it can involve governance, being the administrator for an organization, management, providing services, whether it's providing staff members, supplies, billing, writing prescriptions, or financial benefit. So the understanding of cooperation can be broken apart into two major sections. So one is called formal cooperation, the other is called material cooperation. Formal cooperation has to do with intention. So I would be formally cooperating with wrongdoing if I am intending, desiring, or approving the wrongdoing of another person. So even though I might not actually be doing the bad deed myself, if I'm intending it, then I would be formally cooperating. It can be either explicit or implicit. Either explicit saying, yes, I definitely intend what this other person is doing, or implicit when I might deny that I agree with the wrongdoer's action, but I can render no other explanation to distinguish what I'm doing from what the person who's acting is doing. Formal cooperation, because it involves the intention, is always morally wrong. Because in a sense, if I'm formally cooperating, then I'm willing that the morally wrong thing happen. So it's never acceptable. Material cooperation involves participating in the wrongdoing or providing conditions for the wrongdoing to occur. So it has to do with action rather than the intention. It can either be immediate, which means that it's always wrong, or it can be mediate, which is sometimes okay. Mediate material cooperation can be either proximate or remote, and the greater the wrongdoing, the stronger must be the reason to cooperate. So I'm just providing some really technical terms. So let's provide some examples. All right, so an example of immediate material cooperation. So this would occur when I, as a healthcare provider, I provide for, contribute, or participate in specific circumstances that are going to be essential for another person to carry out a specific objectionable action. According to Catholic tradition, it would never be morally permissible for a Catholic healthcare provider to cooperate immediately in those things that are considered to be objectively immoral. For example, abortion, euthanasia, assisted suicide, and direct sterilizations. So if I were to, for example, work as a surgical assistant to an abortionist, providing the tools to the abortionist in the surgical suite, that would constitute immediate material cooperation. It would not be permissible. It would be another circumstance if I were a physician, an ENT physician, who works in another place in the hospital, is not directly involved in an act of sterilization, but perhaps is part of a medical staff where some of the individuals provide sterilization. That might constitute immediate material cooperation. So some other things that should be taken into consideration when one is considering whether to cooperate in such a way. Immediate material cooperation has to derive from some sort of serious reason, proportionate reason, or moral necessity. In other words, there has to be a proportionately serious reason for cooperation. For example, for the sake of protecting an important good or for avoiding a worse harm. By means of an organizational example, I was called in to advise on a matter that arose some years ago, where a Catholic healthcare clinic in a destitute area that served a lot of uninsured and underinsured was losing about $1 million a year. They were doing great work, but it wasn't going to be sustainable without bankrupting the hospital with whom it was affiliated. The Catholic healthcare provider wanted to continue its mission, but realized it couldn't. So it started to look for partners, strategic partners, community health providers that might be able to come in and manage the clinic, that might have more access to federal dollars than the Catholic hospital would have to be able to provide that service. But a question came up as they were vetting different candidates to manage this clinic. Some of the candidates, actually all of the candidates they were looking at, did prohibited procedures in some of their other facilities, like sterilizations. So the question then comes up: can you affiliate with that individual if they're doing something else elsewhere? At the end of the day, after much more analysis, we felt that they could, as there was a proportionate reason to be able to do so. If they didn't continue to provide care in that community, then these people simply wouldn't have access to care. And yet, there are some things that had to be tended to. This was one. Another was scandal. What is scandal? So meeting the principles of cooperation doesn't necessarily mean that something's a good idea or a wise choice. Scandal, as we understand it in Catholic moral tradition, is an attitude or behavior that can lead another to do evil or to do wrong. It's considered a sin against charity. And it's what we see Jesus reference in Matthew 18:6, where he says anybody who leads one of these little ones to sin is better off having a millstone tied around their neck and being drowned in the sea. I mean, it's a pretty serious thing that we have to be attentive to. Scandal, we should say, it's not a PR problem. It's not, could this show up on the cover of the National Enquirer? Could it be offending somebody's overly scrupulous conscience? But scandal is something that has to be attended to. Sometimes the result of analysis of scandal is going to be that we just really shouldn't proceed because we could be leading others to do wrong if we enter into this arrangement. In other cases, sufficient education can mitigate scandal enough to move forward. A final consideration is that of mission, and this goes both for individuals and organizations. This is a starting point and ending point for our analysis. What's my mission? What are my values? And what good could I be called to do? So we talked a little bit about the principles of cooperation, some of the other things that should be considered, and an acknowledgement that we might be called, some people might be called to different things. It might be cleaner in some ways to affiliate only with those who think exactly like we do. But at the end of the day, it might be somewhat limiting in terms of our mission and evangelical opportunities, and that's where individual discernment and consideration of vocation is so important. So with that, we'll open it up to some questions.
Thank you, Erica. Thank you, Dr. Schuller, for your witness to your wonderful vocation. So, about 5 minutes before we break for lunch, we can have some questions. 2 microphones.
Hi, first off, both wonderful talks. Thank you very much. My name is Warren McGee. I'm an MD PhD student at Northwestern. My question is directed to Erica. Wonderful discussion about the theology of women and their vocation and kind of general principles of femininity. And I was wondering if you could comment, if it'd be too much time in these resources, but comment on the complementary side of masculinity and what the...
Yeah, thank you.
Thank you.
Thank you. Thank you. So it's a question that comes up a lot. I know some feel that men haven't gotten the same kind of theological reflection in recent years that women have. I think it's an area that can actually be developed. I know some have proposed that somebody write an encyclical on the dignity and vocation of men, which is something that's not out there. I think the vision, this anthropological vision, is one that does see men and women as complementary, as equal in dignity, and both as having unique contributions. And at the same time, recognizing that even among mankind and womankind, there's a lot of variation. Not everybody's exactly the same. So I guess I'm going to throw it back to you and say, I think that there's room for more theological analysis to happen there, but perhaps particularly in a Christocentric way, looking at the person of Christ, and then also looking at some of the great male saints. Perhaps Saint Joseph could be a good example as well.
Erica, those questions for you. My name is Miriam. I'm an obstetrician gynecologist, and I'm actually retired now, and at home taking care of my 5 kids, in school and most of them. But as a medical student resident, this question is more for, I'm asking for the students and residents that are probably here. I didn't know any of this stuff. I really didn't learn it until after I retired. And my question is about the wrongdoing. What do you recommend for these students, and particularly OB/GYN residents, or even family practice residents, or I guess internal medicine? All of you, really. When they get in these situations of wrongdoing, I mean, I've given several testimonies on this, and I, in my testimonies would tell people, I said, we would race each other about how fast we could do a tubal ligation. And, I wrote prescriptions for birth control. It's like, that's like my bread and butter. That's what I did. It took care of everything. And so, and then there came a point where, I asked my dad, who was an OB/GYN, like, oh, I think I'm doing something I'm not supposed to be doing. Not that stuff. No, that was okay. But like, oh, am I partaking in a medical induced abortions, right? One of my programs that was called induced labor. And he just said, Amir, if you don't feel comfortable doing something, just let them know. So as I got older and I wasn't the young intern anymore, I felt like I could say that, but I didn't have any reasoning, no support, nothing. And I was okay at that time, but now that was a long time ago. And so I feel like these students and residents, they don't, their situations are different than mine were at the time. And what do you recommend for them?
It's a good case. It's a good question, because I know that so many healthcare providers whom I've spoken, in medical school students, who are medical residents, you're in a tough spot. In particular, I think when you're a student or a resident, because you're the lowest on the totem pole, so you don't have a lot in terms of a voice. You're in a difficult position. To some extent, I think the approach will vary a little bit depending on the situation. I might suggest just being honest and clear, about your conscience from the beginning, or at least when these situations arise. Sometimes it might involve proposing learning things through online modules, which I understand that there are some online learning tools that are available for some medical residents to learn, dosaging and procedures in that way so that you aren't participating in it directly. Another resource that could be available to you if you find yourself in that situation is to reach out to an ethicist. I'd be happy to help if I can. I know the National Catholic Bioethics Center with Father Tad does a lot of ethics consultations, and I would presume in this area as well. So if you can rely on some others as a resource, we'd be happy to help you if you can.
Thank you, Erica. So our last questions before we get our lunch instruction.
Okay. Hi, I'm Ella, and I'm a nurse. But I'm a physician in the Philippines. I went to medical school here out there, and it's just surprising that I heard it twice now that from doctors that they didn't learn any of this in medical school here, because I learned it in the Philippines in medical school there. We went about it a lot. Our teachers went about the natural family planning and all the different. It may not be the same as now, as high tech as what we are learning now, but it was the same principle. And it's just surprising that two doctors who got educated here are saying that they didn't know anything about it. So I went through 2 years of OBGYN training, but I didn't get to finish it over there because I came here. And I started working as a nurse here, and I do say that initially I was doing what the other OBGYNs were doing, prescribing all these things because it's just work until we got convicted with pro-life. And so my question is, why is it not taught in medical school here?
Good question. Good question. I think it's a good question. I don't know if I have an answer to that. I do know there was an article, I think it was an editorial published in one of the family medicine journals recently where somebody wrote it and said, why is it that family medicine practitioners don't know more about this? There's a lot of evidence behind it. So I think that there's a lot of work to be done. And actually, your experience sort of relates to the last question as well in terms of what do you do. As Catholic healthcare providers, I think as much as we can, we need to be prepared to say, well, here's what I do and what I do promote, so that it's not just a no, not just a no, I don't prescribe contraception, but so that we can say, but I am a skilled medical consultant in this method of natural family planning, and I will be more than happy to provide a lecture on this and to talk to my patients about this.
I would just say that I hope this isn't too controversial, but I grew up in a generation that I think we were not taught our Catholic faith as much as we should have been. And I was born in '66. That tells you how old I am. But my Catholic, I went to Catholic grade school, high school, college, was never once taught about contraception, natural family planning. And so I'm not sure I necessarily blame the medical schools. I think that there was a time in the Catholic faith where this information was not taught to any of us.